All right, good evening and welcome to Feet Forward. My name is Chris Martin. I'm with the Illinois Podiatric Medical Association. Tonight's episode, I'm talking like it's a reality show. It's actually edition of Feet Forward. We'll talk about the Midwest Podiatry Conference. This week is a special week for podiatrists all over the Midwest because they congregate here in Chicago for about the second, I think it's about the second largest podiatric medical conference in the United States. Several thousand podiatrists will be meeting at the Hyatt in Chicago, and they'll be taking in a variety of scientific sessions, continuing education, seminars, and networking with their colleagues to sort of improve their knowledge base, learn about new trends, get up to speed on scientific breakthroughs, and maybe learn some new techniques too. So we have Dr. Adam Fleisher with us. He is with the Scholl School of Podiatric Medicine at Rosalind Franklin Medical University. I think I inverted those, but
I think you did.
I'm a little dyslexic tonight. That's okay. So Dr. Fleisher, you first of all, tell me about your role at the college, and then I want to sort of transition into the role you're playing at the conference this week, because I know it's a kind of a special and unique role that you've got there.
Yeah, sure. Thanks for having me here too as well, Chris. So, yeah, my role at the college, I've been up there for about 7.5 years now. I'm an assistant professor, part of the full-time faculty there. I do teach in the clinics up there, the university clinics. We see a lot of, I think, second opinion patients, some of the complicated patients up there in North Chicago. But a lot of the time up there is also spent with students teaching in the radiology capstone. That's essentially what I'm doing, and collaborating with CLEAR. CLEAR is the Center for Lower Extremity Ambulatory Research up there, founded in 2004 by Dr. David Armstrong, and just a, it's a tremendous resource for nearby providers and certainly for us, the faculty up there, to have the GATE lab, the Human Performance Center, all their gadgets and toys, and to have access to their grant writers. I mean, they've been very successful. So
and Feet Forward owes you a debt of gratitude for having trained many of the fine guests that we've had on
That's
here.
what I understand. That's right.
Dr. Chin, Dr.
Right.
Who's the...
well, Chin was a contemporary, but yeah, there were several others. That's right. There was, Dr. Dickey and yeah, several others. Yeah,
I think
Dr.
we got
Kurtz,
that.
Dr. Kurtz.
Yes,
I
Dr.
believe,
Kurtz.
yeah.
She did fine, and Dr. Dickey, we got her right out of graduation, I think.
I think you did first day.
So we appreciate that. So tell us a little bit about some new things that are going on at Rosalind Franklin, and then I want to hear about kind of what's going on at the conference too.
Yeah, the new news at Rosalind Franklin is we do have a new dean. I mean, that's something that's happened recently. We have a new hire in our department, a new chair, very well trained individual with a combined degree, DPM, PhD, Robert Joseph, trained out at West Penn Hospital. So he's a tremendous asset now. He's just come on board, so we're very, very motivated and excited to start working with him and his talents. But I think the biggest changes that are occurring up there that are the changes that are occurring everywhere, all across all the schools, all the podiatry schools in the nation, and that's they're all kind of being in line or merged or affiliated with allopathic schools, DO schools, and
allopathic are MD schools.
The MD schools, right?
DO are osteopathic schools,
indeed,
right?
Right. So you have you basically have the podiatry faculty now taking on the traits and attributes now of our brethren, in the MD and DO profession. So it's I think it's a lot of fun. It is certainly a lot of fun now. We're certainly expected to support a lot of our time up there with grant money if possible. So we spent some time with that. That's a whole brand new concept in podiatry. So, but it is only leading to to really good things, I think. So,
are there certain areas of research that the school is focusing on for the next couple of years that you'd like to talk about?
Well, we are. We just recently have lost our director of the Human Performance Lab, but he was Dr. Najafi, and he was just outstanding. In his ability to be productive in getting funding for grants. And his talent and his skill was really looking at gait analysis, walking analysis with sensors that can be worn on the body in various conditions, and using it for motor learning, and using it to really look at how people are performing outside of the gait lab, which so in their more natural environment. And so there was a project that looked at motor learning and how you can improve your golf swing essentially with that. And he had a project. He has many projects on fall prevention.
Can I enroll in that program? It's not too late. You've seen my swing lately? It's ridiculous. Like Charles Barkley.
He's had a lot of fun with it. I haven't seen it now. No. So right now we're kind of looking actually for a new director, and we're interviewing some really top names out there in the field, and that's kind of been exciting as well. I don't think the direction will be completely different, but it will be not quite the same. I mean, for the past 4 or 5 years, we've been working on fall prevention, which is a huge burden, just falls in general.
Right. There's an association between falls and a higher rate of mortality among the elderly, isn't there?
Without question, yeah. 1 in 3 people over the age of 65 are going to have a fall here in the U.S., and there's an outrageous, many of them are institutionalized after their falls, and of course it just bleeds the healthcare system of money.
Right.
So if you
can prevent those falls, you can make a big dent.
If you can show that a brace, if you can show that a shoe, if you can show that diabetic patients wearing their shoes prevent falls, it's huge. And we're really on that cusp actually of we're doing that very research right now. So.
We'll actually talk about a specific sort of byproduct or side effect of diabetes a little bit later, but I wanted to give you a little minute to talk about what you'll be doing at the Midwest Podiatry Conference and what role you'll be playing and kind of how that fits into the overall scheme of how we educate podiatrists in this country and kind of the training that they go through.
Yeah, they have. My role is pretty limited on it, honestly. But on Saturday, there's a huge, there's a morning-long conference or session called the International Postgraduate Research Symposium. It is basically residents in the area and also fellows. We have postdoctoral fellows up at the college that are presenting their latest research findings. So I am serving as a judge, as I have done for the past couple of years now. It's really the session is all morning long, essentially from 7 to 12. And actually, last year's winner was our former resident, Dr. Dickey. She took the top prize there. We're very proud of her.
She didn't tell me.
Yeah, not everything can get out in 25 minutes, whatever it is. But
we'll have to have her back to talk about that.
And we're very proud of her. She presented the same work down at the national conference at the American College of Foot and Ankle Surgeons and won honorable mention. So it was a top 6 prize out of about 48 manuscripts across the nation. So this is really a time for those mostly local residents and fellows to get their findings out, and it's out. I've had a chance to look at the abstracts. They're truly, it's great work.
Anything in particular without biasing you one way or the other?
There is certainly work that we're presenting, but I won't talk about that. But my residents, but. The fellows up at CLEAR, the fellows at this Center for Lower Extremity Ambulatory Research are presenting essentially using virtual reality to improve balance for patients that have diabetes.
That sounds good. We do have a caller. Go ahead, you're on Feet Forward. How can we help you?
Hi, doctor. You know the old saying, if it works, don't fix it. And one of the crazes I've heard some women are doing is when they have real long, toes, they're going in, some of these doctors are forming where they get their toes shortened. Don't they risk having other type of problems, infections, and so forth?
I think I kind of know what he's talking about, actually.
I'd love to hear it. What, toe shortening?
No, I mean, there was a segment, I think, I don't know if it was on the doctors or what it was, recently that did show... there was a patient who did essentially have the surgery only to shorten the toe, almost for cosmetic reasons.
Really?
It's
to wear a smaller shoe size?
Maybe to look more appealing, to wear. I mean, this has been going on for ages. In the past, there were patients amputating their fifth toe, removing their fifth toe to get into tighter and more narrow-fitting shoes.
Yeah.
So. Yeah, I mean, I don't, nobody advocates necessarily going out to do that, but most people that have a long toe that require a shortening kind of procedure would have some potential pain or discomfort associated with it, maybe at the tip of the toe, maybe a callus at the tip of the toe, or whatever it is. So there are risks with any surgery. There's absolutely no question about it. If it was 100% guarantee, everybody'd be on the table every day, but it's not.
Right. So before you or any of your more conservative, solid colleagues would recommend a procedure like that, you'd have to see some pain or discomfort associated with that.
Yeah,
before
and
you
if you ask, enough and you prod enough, the patients will traditionally tell you there is some pain during some activities, and if that truly is, potentially affecting their quality of life, then it's a reasonable decision, but they do have to understand the risks associated with it. And yeah, I mean, one of the big statements that the American College of Foot and Ankle Surgeons puts out is that we don't advocate cosmetic surgery, and no, very few podiatrists out there do sell themselves as cosmetic surgeons. I mean, it's usually for some pain or deformity or discomfort.
It just goes to show you that you have to start watching shows like The Doctors to keep up on your continuing
You really
education.
do.
Right?
What do you? Yeah, TiVo.
That's right. But getting back to the conference, which is the more serious form of continuing education, tell us a little bit how these conferences fit into a podiatrist education, because you get them in a captive sort of setting, in an academic setting, and you can control them. But once podiatrists graduate, like any kind of healthcare professional, the responsibility is theirs to keep up with their research in their field, and follow trends and things like that. And I believe in Illinois there's a regulation that healthcare providers have to get a certain number of continuing education credits, right?
Just to maintain your licensure, and this is true of any discipline certainly, but podiatry is no different. You do have to achieve a certain number of continuing medical education credits, or every 2 years when your license comes up for renewal. And if you don't do that and you're audited, I mean, there's all kinds of repercussions. So it's a very serious thing. So the events that are offered that do put out a large number of CMEs like this program this weekend they're heavily sought after. They're locally convenient for a lot of the podiatrists here. It's a time also for networking. It's a time for Scholl's put out one third of every practicing podiatrist has come out of the Scholl College. So so essentially what that means is a lot of people have roots here, some roots in Chicago. So it's a fun time to just to see people from from years ago.
It's like a reunion of sorts.
It is.
Isn't it?
I looked at the surgical board review course, and I think that's half my class that's teaching in it. So indeed, I mean, it's a reunion. It's a time to network. But as you said as well, I mean, it really is a time to kind of update yourself. Update yourself on what is the newest or newer approaches to dealing with different things.
Did you see anything on the program that, aside from Saturday, that you're going to attend or pay special attention to, or any of your colleagues presenting that you want to be following?
Yeah, I mean, of course, when your colleagues are presenting, it's fun to watch. There's just Dr. Grady does a phenomenal job every year putting this together. It's a tough thing to get the names and get the people interested, and he's developed a new track. It looks like this year, the intensive small group discussion series. So I think there's about 6 or 7 maybe sessions going on at one time. So I think you're going to have smaller audiences and maybe a more intimate setting. One of my mentors, Dr. Robert Barron, will be talking about imaging for MRI. That's always fun.
Right.
It'll be fun to catch up with potentially Lee Rogers.
Now, Dr. Barron and Evans are giving a session on imaging in the athlete that I thought was kind of interesting, because they are a unique subset of podiatric patients, and we've had separate entire shows where we just talk about sports medicine and how weekend warriors and casual athletes can deal with a variety of problems that come up related to the foot and ankle. They talked. They're going to talk specifically about how athletes are bigger consumers of imaging, and how that the podiatrist has to deal with that. So I'm kind of curious about what your take is on that too.
Yeah, I mean, I talked about this briefly before too. You're right. I mean, we're entering an era where of cost containment. I mean, we are really entering an era where it is not easy to order advanced imaging on a lot of people. And me being part of a physician hospital organization here in the city, I'm actually not rewarded very much at all. I'm actually penalized in many ways financially, if I'm ordering too many studies, and in a lot of ways, I've learned to be a better provider and be a more efficient provider, with that incentive, honestly. But the athlete, yeah, I mean, they have expectations. They want, it's dollars and cents. You need to know right away what kind of pathology they're dealing with, how long they're going to be out. They want to see the physical evidence of what they have wrong with them before they're going to be, willing to, to reduce their activity level, running level, whatever it is.
Mm-hmm.
So athletes are a completely different population, and I'll tell you this: I'm happy that I don't have a tremendous number of athletes, because I'd be broke, I think, ordering MRIs. So, but
we talk a lot of this show, and I think a lot of podiatrists are this way. Most healthcare providers are this way, of a primary care nature. They tend to take a more conservative approach initially. We want to avoid surgery. We want to avoid things that put patients at higher risk.
Sure.
But athletes kind of flip that dynamic on its ear, because they tend to be pushing the podiatrists and other healthcare professionals to order the more expensive imaging thing to get to the root of the problem faster, to return them to training and competition.
Yeah.
So that session, I'm kind of interested in your kind of point of view about how does the podiatrist balance what's in the best interest for the patient with what's good medicine or evidence-based medicine that is now the trend in healthcare.
That's exactly why doctors or family members don't make good patients, because you have too much invested, in them. You can't objectively really evaluate them, and the same probably comes from this relationship you're describing with the athlete and physician. I mean, many athletes you're almost a fan of, if they're a regional or
Sure.
Professional, and it's almost very difficult to be objective with them.
Yeah. We do have another caller. Go ahead, you're in
Doctor,
feed forward.
I have a question. Because we have a lot of people becoming podiatrists here, and because of research now, do we really benefit in terms of the Dr. Scholl Institute being in Chicago in terms of patient care?
I think I'm happy to answer the question. So in 2001, the Scholl College did move from a kind of downtown location. They were right there in the Gold Coast. That's essentially where I graduated from.
Right.
It was a great time. It was actually a big draw for podiatry students. But
Sure.
But they did serve the community quite nicely there, because if we're the underinsured, uninsured population in the city had access right there to the college and to the clinic. The clinic was in 2001 moved up to the North Chicago area. That's kind of Lake Bluff, Lake Forest, Gurnee, Waukegan area. So
Right.
quite a further north.
Diverse population up there too.
Right.
Actually.
But so we don't see nearly as many patients from the Chicago area. But the mission of the school is absolutely to serve underinsured, uninsured patient population, the surrounding community. So we, I think in that respect, the city does benefit from it. It puts out a tremendous number of students who do a tremendous number of their residencies here in the area. Many of them stay in the area. I think because of that, you have a greater selection. If you're going to a podiatrist out there, you have more opportunities and options than you would in a smaller city. So I think the city does benefit, maybe indirectly. I mean, another way I would say, we were just at the Diabetes Expo.
Right, I was going to mention that, because I was there Saturday too. Yeah, at McCormick Place, sure.
And
you guys had a big booth. They were doing a lot of
there were 200 patients who came through who got diabetic foot screenings. That in another city, not going to have that certainly. So, and they were all performed by faculty and students of the Scholl College. So, I mean, there are probably a tremendous number of ways, that the city's benefiting from having the school, local.
That's great. You mentioned the Diabetes Expo, and IPMA had a booth there last Saturday too. So we saw the huge space that Rosalind, Franklin, and Scholl was using, and all the people that were lined up into the aisle for waiting for their screens, which was great. Which is a segue to the other question I wanted to ask you about in terms of the Midwest Podiatry Conference. In terms of the session that I'm most interested in is the one by Dr. Ritchie, where he's going to talk about how podiatrists and patients have kind of conspired to prevent diabetic ulcers from being healed the way they should. Podiatrists know what the right recommendation is, but Ritchie is going to talk about that sort of tension between doctors and patients and how that creates some problems. So what I want to do is have you talk to patients and give the patients a message about if they have diabetes, if there are patients with diabetes and they're at risk for ulcers, foot ulcers, what do they need to do how do they need to work with their podiatrist to make sure they get optimal healing in a proper sort of setting?
So you're talking about the patient who maybe has the ulcer?
Yeah, or maybe at risk. Yeah, maybe something to think about in terms of their long-term sort of
Well,
care.
the first thing they need is a good primary care physician. Okay, they need someone who's quarterbacking everything, who hopefully has a very good relationship with the foot provider. I mean, that's probably the first and foremost. So, because most primary doctors will have them see a podiatrist that's either in their network, someone they're comfortable with, someone they're familiar with. And if everyone's at different level of risk of ulcerating, I mean, or having complications with their feet. Many diabetic patients out there are at almost no excess risk for having an ulcer, and many diabetics are at imminent risk. So it does take somebody who has that kind of special knowledge, who can do a good exam to risk stratify the patients. And podiatrists are well trained to do that, and we do that routinely. I mean, some visits are just for that reason, to risk stratify the patient, see that they need to be returning maybe every 6 months, every year for a nice foot exam, 3 months, whatever it is. But you mentioned, you were talking earlier about the dynamic. It is absolutely hysterical. Because I think about this, and it's funny that Rich, you'll be talking about that, because I think about that, in the future, in the very near future, it will not pay to have that relationship where you're seeing the patient back with the chronic ailment like that, because you're going to be paying, you're essentially going to be reimbursed on, your outcomes and your performance.
Do you think then the physicians will then be able to resist that pressure that patients put on to go one area versus the other?
They're going to have to say it's this way or the highway, because they're just going to have to, because you just can't have. It's tough to have those patients who just don't want to get on board with your plan. I mean, it's going to adversely affect your bottom line, and not more than you're a part of a medical home, potentially in this new model. And it's going to be affecting everybody around you who refers patients to you, the vascular surgeon, the primary care providers, family doctors, etc. So it's it's a fun relationship now, to see the patients back and to see that maybe they're minimally adherent, or but in the future it's just not going to pay to keep that up. So.
And what about
when I say pay, I mean more than just it's just.
Well, I
think of outcomes and everything.
Yeah, I mean the public is becoming increasingly more sophisticated about how physicians and hospitals are paid, and I think what you're hinting at is payment strategies and outcomes are now becoming more aligned, where in the past they weren't always lined up perfectly as they were. Medicare, for instance, bills are reimburses physicians and hospitals based on a fee for service, not a pay per quality or an outcome sort of basis. So, but those are starting to change gradually, and hopefully some of the things that we talk about at the Midwest Podiatry Conference will help kind of realign those things, at least in podiatric medical care. What else? We got about 2 minutes left in the show, so any kind of closing thoughts you have about the conference that you want to say or cover before we leave?
Not specifically. I mean, there is a session on the EMR there tomorrow. That's
the electronic medical record.
Yeah, the electronic, and that's one of the things driving this, accountability and kind of things like this. So,
are podiatrists part of? I mean, podiatrists are typically solo practitioners. They're not typically part of big groups or hospitals. And EMR is very expensive to
Absolutely.
implement.
That's why it's a real fun time for the practitioner who's been out there and just thinking about retirement. I mean, this is basically, this is letting them know this is the time. But, I mean, it's a huge expense. With ICD-10, it's a big expense for...
What is the promise for patients? What's in it for patients? Why is EMR good for the public?
The amount of data that can be tracked, for outcomes and everything else, and the better communication that will occur between providers. I mean, and fewer, redundancy in terms of tests and things like this being ordered, because, essentially we'll all have access to everyone else's records. So, if there is an efficiency element to this EMR.
Great. Well, 30 seconds left. I want to thank you for coming on. Always good to have someone from Rosalind Franklin and the Scholl School of Podiatric Medicine here. And I forgot to mention this, a fellow alum of the University of Illinois
Oh, indeed.
at Chicago School of Public Health. He and I share that. And we're going to have a little alumni meeting after the show here. But for all of you who do not have a podiatrist, you can go to the IPMA website. That's ipma.net. Click on Find a Physician, punch in your zip code, and you'll get 3 referrals to a podiatrist near you. Until next month, thanks, and we'll see you then.